my name is Dr. Cathy Eng, and I am a professor here at Vanderbilt Ingram Cancer Center in Nashville, Tennessee. I'm the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and I'm the co-leader and co-director of the GI program here at this institution. And welcome to the HPV Cancers Alliance podcast. My experience with treating anal carcinoma is largely as a clinical researcher. I conducted multiple phase 1/3 clinical trials in GI malignancies, but I'm also quite well known for doing quite a bit of clinical research regarding the treatment of squamous cell carcinoma of the anal canal.
Thank you for finding time for us today. So I'll jump right in and ask the questions. So
Sure.
the first question I have is about oral chemotherapy versus, so the F5U, it's sometimes given with a port or a PIC, and sometimes it's oral chemotherapy. What are your findings regarding that? Is there a preference for the oral chemo versus the other chemo?
So most of the data historically is not in anal carcinoma. Most of the data historically is in colorectal cancer, which is a much more common malignancy. So the data is equivalent for 5FU and oral capecitabine in regards to response. It just has different side effects. So 5FU, depending upon the way it's administered, can be administered as a bolus injection or a injection, depending upon what it's given with, that requires a port or a PICC line. Oral capecitabine is advantageous to some individuals because it is a pill form, but keep in mind for somebody that is not good at taking multiple pills, if you are if you're more prone to having nausea or motion sickness, I do not recommend oral capecitabine because if you have any nausea or vomiting, you cannot necessarily make up the dose. So at least with the IV 5FU, we know exactly you'll receive the drug that it's supposed to be administered at the dosage that's recommended. The other disadvantages with the pill form is that obviously it's not just one day. It's usually 2 weeks full, days 1 through 14 out of every 21 days. So 14 days of medications with multiple pills and 2 divided doses throughout the day and 7 days of rest. Whereas if you get IV 5FU, it's a 1 to 2 day administration, depending upon how the drug is administered and what it's being provided with. Also, if you are elderly and do not have good kidney function, you are not recommended to receive capecitabine unless you have good, called creatinine clearance.
So I'm an anal cancer survivor, and I had the oral chemotherapy for 27 days, and it was every week. So it's given every day during treatment.
So it depends on what you're talking about. So if you're doing it during radiation, it may be administered in a different fashion. Whereas if you're receiving it for part of systemic therapy for metastatic disease, it's not given every day.
Oh, I see. So it's different if it's stage 1, 2 anal cancer and then stage 3, 4 anal cancer. I understand.
Well, stage 4 versus the earlier stages. So radiation dosing is different.
I understand.
The schedule is completely different too. That's only Monday through Friday.
Right.
But if you get it for metastatic setting, it's Monday through Sunday.
I see.
For 14 days.
And then
it's a higher dose.
Is the oral chemo less toxic? Does it have less side effects?
No, it's not less toxic at all. So I think it's very important what you stated, because it sounds like you got it during radiation treatment, but the dosing during radiation treatment is automatically less than what we would give you if you were getting it for systemic treatment for the rest of your body. We are just giving it during radiation treatment to enhance the radiation. It is not full dose treatment.
So for those who are getting chemoradiation, you're saying it really doesn't matter which one they get. Neither one is less toxic than the other.
Yes. In regards to efficacy, they're equivalent. But in regards to toxicities, you are more prone to hand-foot skin syndrome with oral Xeloda or capecitabine, which is not very common with IV 5FU.
Interesting. I had always thought that there were less side effects.
No, more risk of diarrhea, more risk of hand-foot syndrome with the capecitabine, especially if you're getting it for treatment as part of systemic therapy, for instance. It just depends upon what your doctor is providing it with and for what reason they're providing it for.
Very interesting. And then regarding the mitomycin, do you recommend 1 or 2 doses? So I understand that not everybody gets 2 doses for anal cancer stages 1 through 3. What do you recommend?
So there is an ongoing trial at this time, specifically for early stage patients with no node involvement called Decrease. So I recommend you wait until those results because it's looking specifically at a full dose of 10 milligrams per meter squared in the earlier stage setting. But for the everyday patient, it depends very much on what stage of tumor it is. So that depends upon the T stage and the N stage. The T stage has a big bearing because that's the size of the tumor, and also depends upon the other comorbidities of the patient, depends upon how frail the patient is or how healthy the patient is. So in fact, it could be one dose or two doses. I still vary it based upon the patient that's in front of me.
I see. I know. And do you know how many patients get only one dose? Is
Yeah,
that
I
common?
won't have that information. That's really practice preferences. That's why I suggest that you wait to get the results of the Decrease trial that is still enrolling for earlier stage patients, because that will really give us additional information.
Interesting. Good. Great. And then another question that comes up for many patients is the risk of taking a break. So many patients who are getting
So
chemoradiation.
sorry, so you're talking, okay, thank you. So you're talking about early stage. Yes.
I'm talking about early stage patients 1 through 3 who are getting chemoradiation and have wounds and skin problems and want to take a break.
They should never take a radiation break. I'll be very honest with you. The data is well documented in head and neck cancer, where in fact it actually causes the tumor to grow faster, and you're at more risk, a higher risk for these occurrence and for not having a complete response. So we expect patients to have radiation dermatitis. That is expected from treatment, especially with mitomycin C. But you need to, if you have concerns because of diarrhea or other associated symptoms, we would prefer you hold the chemotherapy if that's a chemo week, but continue the radiation treatment. Obviously, there are certain settings where it's a holiday, so the machines may be down for a day, or the machine may be down because of technical issues in general for a day. That's okay. We're more concerned about prolonged delays, a whole week delay, for instance, because of radiation dermatitis. Once again, it's so important that a patient communicates well to their radiation doctor and their medical oncologist about any skin toxicities or discomfort that they're having, because there's ways to address that. There's different solvents for addressing the radiation dermatitis, and it depends upon the grade of radiation dermatitis. So usually we will ask you to look at your bottom because we want to look at your skin. If it's not me, it will be the radiation oncologist. And it is so lucrative. It's imperative that radiation not be delayed for a significant period, because it actually puts the patient at risk for failing the ability to be cured with their chemoradiation therapy.
And it increases the risk of a recurrence, correct?
I'm sorry?
Does it also increase the risk of a recurrence?
Oh, it increases basically your risk of failing to have a complete clinical response or cure. Yes.
I understand.
Yes,
That's very
definitely.
important for people. That's really important for people to know, because patients want a break.
Right. Now, none of my patients, I am very particular about my radiation therapy. And so if anything, I often try to convince patients to stay with a radiation oncologist group or practice that is very familiar with treating these cancers, because the issue is that you need that experience not only to reduce your toxicities, but also to make sure that the patient stays on track and to complete their treatment, because this has long-term impact on their outcomes, as you mentioned. Now, I mentioned to you earlier that there was data in head and neck, but eventually there is old data in early stage carcinoma, and then it was updated data again just recently, just trying to reiterate the importance of staying on track with the radiation schedule.
Thank you for that. That's very important for people to know. You mentioned radiation. Is there a preferred type of radiation that you think is better than another type of radiation?
Well, I'm not a radiation oncologist, so I think
No, I was
yeah,
just
so that I just want to be very clear. We do recommend IMRT, or intensity modulated radiation therapy, which is more cone down radiation therapy to reduce the toxicity to normal organs. But I am not a radiation oncologist. I wouldn't necessarily be the expert on telling you exactly what my preferences would be since I don't do the radiation planning. The dosing or the schedule of the radiation therapy or the duration of the radiation therapy is very dependent upon the size of the tumor and whether or not there are lymph nodes involved. But also, it's also important as a woman that the consideration of sexual dysfunction is taken into account early on. And so you want to make sure to ask your radiation doctor about vaginal dilators, if it's appropriate in your care and how to incorporate that. I think it's very important that patients see a gynecologist early on before they get their treatment. And as well as if you have very young patients, fertility discussion is extremely important.
Yes, good, thank you. So I won't ask any more about radiation.
I
Can
can't
ask
tell you about the
proton
technique.
radiation or not? Because a lot of patients are curious about proton radiation. Do you know whether there's enough research on it, or?
There's not a lot of great data regarding proton therapy, and honestly, not all institutions have a proton beam center. It's largely only approved for prostate cancer, and unless you're utilizing it for clinical trial purposes. And so not every institution and not every community center is going to have a proton beam center. There's not a lot of great data specifically for anal carcinoma at this time.
Thank you. That's helpful. And then another question, I've talked to a number of patients and got questions that they're curious about, but another question that came up is, what do you recommend if a patient still has a residual tumor at 3 months and then at 6 months?
Are they HIV positive or HIV negative?
Well, perhaps you could tell us about both situations.
So I ask that because HIV positive patients will have a longer delay depending upon what their CD4 count is in regards to response. So I always give them a little bit of extra time as long as it continues to regress. An HIV negative patient, there's data to show that you can wait up to 6 months if the surgeon feels comfortable. Please note this is a multidisciplinary malignancy for early stage disease because it involves a medical oncologist, a surgical oncologist, and a radiation oncologist. So everyone has to be on the same page. So if there's residual tumor at 3 months, as long as it's not progressing, and as long as the surgeon feels comfortable waiting another month or two before additional diagnostic tests are completed, is fine. But if the patient's having symptoms, that's a different story. And then that is really a discussion with the surgeon that whether or not an APR or loss of the sphincter with a permanent colostomy would be recommended at that setting, or are they more comfortable are they comfortable waiting until 5 or 6 months? It's really dependent upon the patient's current symptoms, whether or not the tumor is stable and slowly regressing. But if there's profound progression, then the patient likely needs an APR.
I understand. Yes, that makes sense. And then the other question is about, since we're talking about surveillance, patients are often confused. Some patients get a PET scan, some patients get a CT scan. What do you recommend in terms of surveillance for the first 5 years? And then what about after those 5 years?
So there's really no need for additional imaging after 5 years. If you are free of disease at 5 years, I think that you are pretty confident that you can just follow up with your primary care physician and or your gynecologist, because you have to be careful that the patients are still at risk for other HPV associated malignancies. But a CT scan is the standard of care. And keep in mind, not everybody will get approval for a PET scan for follow-up. A CT scan plus or minus a PET scan is reasonable. I don't always order a PET scan on my patients because I think the quality of the CT scans, keep in mind, CT scans vary per hospital. So I feel confident in the quality of our CT scans here at our institution that I don't necessarily need a PET scan unless there's something non-specific that then I need to follow up on. That maybe another CT scan would not be helpful, but maybe a PET scan may be helpful in that setting. Because a CT scan looks at anatomy and a PET scan looks more at what's called avidity or increased uptake. So I utilize the purpose of a PET scan for non-specific findings on a CT scan. I do not choose it as my primary test. And some individuals may choose a PET scan as their primary test, but overall, the majority of individuals usually at least do a CT scan because not everybody has access to a PET scan.
Is there any downside for having a PET scan? Is there too much radiation for the patient, or any reason?
It's just a very expensive study relative to it.
And then I guess my other question is, you mentioned
Also,
HPV.
I'm sorry, I have to go back to that. But for some patients, if their kidney function is not appropriate for any IV contrast, then a PET scan would be appropriate because then they can't get a good CT scan.
I understand. That makes sense. And then I guess I have another question. You mentioned that we're still at risk for other HPV-associated cancers. I have two questions about that. One is, do you know how likely it is for us to get another HPV-associated cancer? Or
I can't remember the numbers off the top of my head. It's actually very well known concept regarding HPV malignancies, even for head and neck cancer, for instance. You just have to be cognizant these patients do need a follow-up just because there's a concept called field cancerization. So anything in that area that is at risk for developing HPV is obviously putting you at risk for an adjacent organ or site to have another HPV-associated malignancies. And obviously, we know cervical cancer is commonly associated with HPV as well as anal carcinoma.
So would you recommend that the people who survive one type of HPV cancer get screened constantly for all the other types? If you have anal cancer, you should get pap smears for the rest of your life.
Well,
Pap smears.
so I am a full advocate. So I know there's data from gynecologists recently that say if you had a normal pap smear, you probably don't need another one for every other year once you get to a certain age. But the reality is, for any patient that has a history of anal carcinoma, I tell all my patients, no, that is not the recommendation for a patient with a history of cancer. And I think it's very important that that is communicated to their gynecologist. Their gynecologist may not be aware that they were treated a year or two ago for locally advanced disease. So I unfortunately have seen cases of anal carcinoma that have involved the vulva, vaginal region, or they're not sure if it came from the cervix. You just have to be very careful. And once you've been cured of this disease, you obviously want to make sure that you stay disease-free.
And so another question I have is regarding the Anchor study. Does the Anchor study suggest that survivors of anal cancer should have anal HRAs and anal PAPs for the rest of their lives?
So the Anchor study is not for patients that have had cancer yet per se. It's for pre-malignant lesions. And it was specifically in a high-risk HIV positive patient population, if I recall. So it's a little bit of a different study.
So then let's separate it from the Anchor study. Do you recommend that survivors of anal cancer get high-resolution anoscopies and anal pap smears for the rest of their life? Could we get another anal cancer from HPV again? Should we be monitoring for that?
Well, you're going to be monitored for it regardless, right? Because you should be following up with your physician, right, until you hit the 5-year interval, and then you should still be following up with your gynecologist, right, until you for your regular evaluations and your primary care doctor.
And should the gynecologist be doing anal paps and high-resolution anoscopies?
So I don't think there's enough data to support that that's the case, because not enough people know how to do that, and not enough people actually have that accessible to them. I think the most important thing is accessibility, right? So you just want to make sure that your physician does a digital rectal examination, you get a proctoscopy and or flexible sigmoidoscopy as you follow up for your regular intervals. And don't forget, every patient also is at risk for colon cancer, because that's also the second leading cause of cancer death in this country. So hopefully, if you've had a good colonoscopy, they will also be looking at your bottom when they insert the colonoscopy. So I say that because people forget to get screened for other cancers that are more common. So there are plenty of opportunities to still be followed. And it's very important that you had some patients that tell me, I haven't had a digital rectal examination for so-and-so period. And I have to remind individuals, this is a multidisciplinary team management malignancy. So somebody between med-onc, rad-onc, and surg-onc should be doing a digital rectal examination during your surveillance period on a regular basis.
And after the 5 years?
As I mentioned, you should still be seeing your primary care doctor. And I encourage all my patients to get a primary care doctor.
The thing with primary care doctors is that they, in my experience, they don't know much about HPV.
Well, That is your job, is to remind them that you have this cancer. And it's not very hard to do a digital rectal examination.
All right. And then let's talk about stage 4 patients and what's new and what do you recommend in terms of immunotherapy? Some stage 4 patients asked whether it's better to combine immunotherapy and chemotherapy. What's the state of trials right now? What would you recommend to a stage 4 patient, and what do we know?
So there's an ongoing trial at this time that I am running, which is a national phase 3 clinical trial specifically to address that question of chemotherapy plus or minus immunotherapy in newly diagnosed metastatic patients. And that trial is available across the nation at multiple sites. It's 2/3 completed in regards to enrollment, so hopefully we'll have some answers soon. I highly encourage individuals to participate in that clinical trial because that's the only way you're going to get chemotherapy plus immunotherapy in the newly diagnosed setting. Immunotherapy is currently only approved in the previously treated setting based upon current treatment guidelines.
I see. And hopefully you can send us a link to that and we can post it at our website so that
Sure,
we can access it. Thank you. Great.
be happy to do so. Thank you.
And anything else stage 4 patients should know?
Well, I would say that if you've received more than 1 or 2 lines of therapy or even just 1 line of therapy, please reach out to your closest academic institution. Go to a provider that is very familiar with treating anal carcinoma. It's less than 10,000 cases per year, but keep in mind it's been rising in incidence, a little less than 3% per year for over 20 years, as far as I can recall. And so you want to go to a provider that's familiar with treating this malignancy because depending upon where the metastatic disease is, patients have different discomfort depending upon where their metastases are, tumor pain, they could have ulceration of superficial skin sites, vaginal involvement, etc. So you want to have somebody with the expertise to be able to guide the patient, and then you also want somebody that has access to clinical trials.
Thank you. And then another question about ctDNA testing. Should we be getting ctDNA testing? Is it relevant to patients with HPV-associated cancers at the moment?
So it
What's the
depends
status
on
of that?
what reason you're ordering the circulating tumor DNA for. Are they ordering it for molecular marker analysis because they're trying to see what other lines of therapy
To
are
test for
recommended?
possible recurrence?
So I think you mean in regards to molecular residual disease or minimal residual disease.
Yeah.
There's very little data in regards to circulating tumor DNA in any GI malignancy for that matter. The best data, and it's still only in colon cancer, and even in colon cancer, it has not been well established. There are current ongoing trials in both stage 2, 3, and 4 disease in colon cancer. So the fact that there's still ongoing clinical trials in colon cancer, and that's the most established area for circulating tumor DNA, very, very early in development for anal carcinoma. There is literature to support HPV circulating tumor DNA, which is different. And that has been tested in head and neck cancer. They're a little bit further along, obviously, because that's a more common cancer. That is actually a part of the test that is being completed in the decrease trial, as I mentioned earlier, for early stage carcinoma, and then my trial EA-2176 for newly diagnosed metastatic patients. That's actually part of the clinical trial that I'm involved in as well. And then it's also involved in another clinical trial that's already been completed enrollment a couple years ago, 2165, regarding the role of adjuvant immunotherapy in the high-risk patient that's completed chemoradiation therapy. But we do not have any of that data yet. The final data is pending.
I understand. And so just to clarify, your studies regarding reduced dose chemoradiation for early stage anal cancer patients, there's no conclusive data yet. It's unclear.
It's still enrolling.
Oh, okay.
It's
Right.
almost done.
So we don't know yet whether we can whether it's possible to reduce the doses there.
Correct. Yes. The trial is almost nearly completed though, so we should have an answer within the next 1 or 2 years.
Great. And then what is the best treatment for neuropathy?
For neuropathy, well, neuropathy can apply to a lot of different chemotherapy agents, not just anal carcinoma, but other cancers. Actually, it's very dependent upon the patient. There's several drugs that are available that can be prescribed to the patient that are usually utilized for diabetic neuropathy. They can cause drowsiness in some patients, and there's different tiers of medications. And some of the more common one is gabapentin, and then after that, there are newer ones such as Lyrica, etc. But some patients find acupuncture and some patients find massage therapy to be very helpful.
Interesting.
The use of supplements such as B6, B12 have not been helpful. We've investigated that in the past. That has been published. And so that is not a beneficial recommendation, though.
Do you feel overall that treatments for anal cancer have improved over the years?
Oh,
Or
yes.
patients now?
Oh, without a doubt. There's increased knowledge base. There's significant data to show that you shouldn't go straight to an APR within 4 weeks of completing your chemoradiation therapy. That's what they used to do. They used to send every single patient that had any evidence of residual tumor straight to an APR or loss of sphincter with a permanent colostomy 4 to 6 weeks out. And so, yes, that has clearly changed.
And side effects are being reduced, long-term side effects are
Well, and
being.
also the techniques for radiation are improved, and I think just the knowledge base is improved. So it's significantly better.
That's good to hear. That's good to know. So, are there anything else that you feel that anal cancer patients should know? That any
Go to a provider that is familiar with treating this disease. I do not recommend going to I think it's fine if you are very comfortable with your provider and you are comfortable with your radiation oncologist. But because of the rarity of the tumor, because it's less than 10,000 patients per year for all stages, I think it is imperative to go for a second opinion to make sure you are getting the right treatment. Fortunately, it is not helpful if you already initiated treatment with chemoradiation therapy to go get a second opinion in the middle of your treatment, because no one is going to stop your radiation therapy. So if you want to get a second opinion, you need to do it before you start your chemoradiation therapy.
I really like your advice. I'll just say personally that I went to 3 different cancer centers before I started treatment. And then I went to Memorial Sloan Kettering. And I am so happy. The first week when I was diagnosed, I went to 3 different places, and I'm so happy I did that. And there was a huge difference between less experienced and more experienced.
It makes a very, very big difference. And I remind a lot of patients tell me, oh, it's very inconvenient. It's Monday through Friday radiation for 5 weeks. And I kindly remind patients, this is 5 weeks of their life, Monday through Friday. They have their weekends to themselves for me to cure them of their cancer. So I'm only asking for 5 weeks of their life for their locally advanced disease to cure them and avoid surgical resection and avoid loss of their sphincter permanently. So I think once you put that in perspective, people tend to stick with their caregiver who they feel most comfortable with.
That's very important advice. And I'm very glad that I did that myself. And so I'm happy that you said that. Thank you so much. Anything else that you feel we should tell patients about?
Oh, I think it's really important to just spread the word and acknowledge the fact that anal carcinoma is not a disease to be embarrassed about. This is a common cancer that's been rising in incidence from a very uncommon setting of less than 3,000 cases per year to now almost 10,000 patients per year. And that's just in the United States. Internationally, it's roughly anywhere between 20 and 35,000 cases per year. So this is an HPV-associated malignancy for the majority of individuals. And the fact is, all breakthroughs that we make in this malignancy can have impact on other HPV-associated malignancies. And please encourage vaccination for adolescent children for preventative reasons to prevent HPV-induced malignancies, associated malignancies, which includes head, neck, and cervical cancer, as well as other HPV-associated malignancies, PNL cancer, for instance. Also, have that discussion. Sometimes a chronic hemorrhoid is not a chronic hemorrhoid. And I hear that too often, that I was informed it was a hemorrhoid, and that's why I waited long and I was treated with this and this. And the reality is that if something doesn't go away after a few weeks, and I'm saying, when I say a few weeks, I'm literally less than a month or even 3 weeks, see your primary care physician. And if you don't get the answer that you are seeking, go see a different physician, go to your gastroenterologist, go to your gynecologist, speak to someone that you feel comfortable with. This is nothing to be ashamed of.
That's really important advice too. Since you mentioned vaccines, I have another question. Is there any benefit to people who've already had an HPV-associated cancer getting the vaccine? Would it prevent recurrence? Is there any research on that?
There's no great data. A lot of do ask that there's no great data. Are always at risk for another HPV-associated malignancy. So I think it's not, tell patients if they feel more confident in getting the vaccination, they should do so. It's very inexpensive. It's less than $500 for, the 2 vaccinations that are recommended. And again, it's for prevention.
Great. That's very good to know. Anything else we should know?
No, I think that's it.
We covered it. Okay. Thank you so much for giving us your time. This was incredibly informative and extremely helpful. And I'm glad that we can get this information out there. Thank you so much.
Thank you so much for inviting me. I'm very honored to be able to reach out to the audience members. And I really hope, once again, other individuals learn from this podcast and spread this information to others.
Thank you very much. Thank you.
Thank you for this opportunity.
Thank you. Thanks very much.